Hey, it's Rob Fitzgerald once again. Thanks for tuning in. We're going to talk about therapeutic drug monitoring of some common drugs. We've already talked about anticonvulsants. We're going to talk a little bit about antiarrhythmics, antimicrobials, and immunosuppressants. So these are common drugs that we see in the clinical laboratory. So Theophylline is one of the methylxanthines. It's related to caffeine. It's used to help treat difficult cases of asthma. It works by inhibiting phosphodiesterase, so second messengers. Its pharmacokinetics are age dependent, so if someone's been on Theophylline for a long time, their pharmacokinetics could change, and therapeutic drug monitoring might be helpful to maintain them in that 10 to 20 range, which is typically thought about as being the therapeutic range for Theophylline. It shares metabolic enzymes, so dilantin and phenobarb induces metabolism, increasing the clearance by twofold, so that's huge. So TDM is useful if you're adding drugs. So as we said, it has a reasonably well-defined therapeutic range of 10 to 20. Overdoses are treated with activated charcoal, so absorbing the drug in the gut so it never gets systemically available. Hemodialysis or hemoperfusion, hemodialysis probably being more preferred. Chronic intoxications cause toxicity at lower concentrations than acute. So really sort of nonspecific toxicity, nausea, vomiting. It causes tachycardia, and it causes an anion gap metabolic acidosis. Digoxin, a cardiac glycoside used to increase contractility. It works by inhibiting sodium and potassium ATPases, which end up increasing calcium concentrations, allowing the myocytes to contract better. Not a first-line drug, but it is still used. It's variably absorbed. It's about 25% protein bound. Has a really narrow therapeutic range, so 0.9 to 2 nanograms per milliliter. It's also difficult to measure. There's some endogenous substances that sometimes cross-react with immunoassays that can give you false results. So really important to draw this as a trough. One of our most common causes of errors is pre-analytical, where we get a digoxin that's not a trough. It's above the 2.5 range, so it becomes a critical value, and we have to call providers. And then we just find out that, in fact, it was not a trough. So at least 8 hours, and typically trough should be drawn right before the next dose. So sort of characteristic toxicity of digoxin is this visual disturbance where they see these weird green-yellow colors. And they think that that's maybe why Van Gogh painted all those crazy starry nights and things, because he was on digoxin. It also causes AV blockade and is sometimes used to cardiovert people because of its ability to block AV transmission. As I said, it's difficult to measure because of the endogenous acting digoxin-like substances. Procainamide is an antiarrhythmic. It has an active metabolite NAPA and acetylprocainamide, and so it's important to measure both procainamide and NAPA when you're trying to interpret. So you essentially just add the concentration of procainamide with the NAPA, and it should be in that 5 to 30 milligram per liter range. There are fast acetylators and slow acetylators, so some people form more NAPA, and so again, that's why it's important to measure both compounds. As far as intoxication goes, if you take too much of it, instead of its therapeutic effect of being an antiarrhythmic, it actually starts to prolong the QRS interval, and you get AV blocks. So you get arrhythmia. So you're giving a drug in a situation where patients already have arrhythmias, and if you take too much of the drug, you create arrhythmias. So TDM can be very helpful to figure out, are they having arrhythmias because of their disease state or because of too much drug? Aminoglycosides, one of our antibiotics classes, it includes amikacin, gentamicin, tobramycin, fairly commonly monitored. They're poorly absorbed, so typically they're given IV. or IM. Peak to determine therapeutic response, so minimal inhibitory concentrations. We correlate these with the microbiology lab to see, are they sensitive and at what concentrations. Peak to determine therapeutic, and trough for toxicity. Fairly characteristic toxicity of these compounds is ototoxicity, so they cause ear toxicity as well as renal toxicity. They're renally cleared, and so that can put them on a very bad cycle, and again, that's another good reason to do TDM for these compounds. Vancomycin is another antibiotic. It's effective against gram-positive organisms, like the other antibiotics we just talked about. It's ototoxic and nephrotoxic. It's also renally cleared. So again, why we measure concentrations to make sure that we don't get drug concentrations so high that it causes renal damage, and then drug concentrations get even higher. So 10 to 20, depending on the infection. Immunosuppressants, sirolimus, tacrolimus, and cyclosporin are our three primary immunosuppressants that we monitor. Probably sirolimus the least, followed by cyclosporin, and then tacrolimus. So it's used in renal transplants. It inhibits T cells. It also has B cell activity, and usually it's used initially with cyclosporin and steroids, and then you depending on the protocol, but sometimes they're cycled off the sirolimus and up-titrated on the cyclosporin. So, so that's what this is saying. So that's the reverse. They actually take them off the cyclosporin and up-titrate the sirolimus. Target concentrations 4 to 12, sort of depends on what's being transplanted, excreted in feces, and it makes sense that if you're immunosuppressing people, they get infections, so CMV infections happen. Hypertriglyceridemia and hypercholesterolemia are also adverse effects. Cyclosporin, again, suppressing graft versus host in transplants, variably absorbed. We're typically measuring whole blood concentrations because the immunosuppressants concentrations in whole blood seem to correlate better with immunosuppressive effects. Therapeutic range for renal transplants is 100 to 300. Cardiac is a little bit higher. And these are given to renal transplant patients, and they're also renally toxic. So we want to monitor the concentration to make sure that they're not being rejected due to too much drug, so we're not causing actual renal toxicity. Tacrolimus is probably the most commonly monitored immunosuppressant. It's really was sort of responsible for the success of kidney transplants. It's given with steroids, immunosuppressive doses of steroids. That sort of makes sense. Works through T cells. Typically, concentrations are targeted, 5 to 20. With chronic dosing, it's more on the, 4 to 8 range, something like that. It's also excreted fecally, has a half-life of about 2 hours, so it's going to take, about 2 days, so it's going to take about 8 days to come to a new steady state if you make a dose adjustment. It's nephrotoxic, and its primary use is in, or at least one of its primary uses is in renal transplant. So again, another good reason to be doing TDM. Generally doesn't get used with cyclosporin. It can cause severe hyperkalemia, so measuring electrolytes would go along with TDM. Other toxicities are neurotoxicity, headaches, tremors, changes in motor function, things like that. So finally, this is just a list of some of the common drugs, not really necessary to memorize, because when you get a value back, it's going to give you a therapeutic range, but in case if you need it for a reference. So thanks again for tuning in, and we'll see you on another Quick Hit in Lab Medicine.